Hi, Dr. Villena-Vargas. I'm Stephanie Williams. I am a patient living with lung cancer, and I'm a patient advocate with LCFA. Thank you for joining us today.
Thank you, Stephanie. It's great to have this conversation with you. My name is Jonathan Villena-Vargas. I'm a thoracic surgeon at Weill Cornell in New York City and also a surgeon scientist.
Well, Dr. Jonathan, I have a question. A lot of times we hear a lot of abbreviations thrown around, a lot of alliterations. What I have is something called ALK or ALK positive or ALK positive. What does that mean?
We started studying kind of mutations in lung cancer a couple decades ago and experimentally a long time ago. And what we see is that there's certain mutations in certain cancers, and these certain mutations can actually promote a cancer. And ALK, which stands for anaplastic lymphoma kinase, was actually originally discovered in lymphoma patients. But what we see is the same mutation is found in lung cancer patients in around 4 or 5% of them.
4 or 5%. That seems like a pretty low rate of the overall lung cancer population.
So it is. The other most well-known one is something called EGFR, which we see in around 15 to 20% of patients. But 4 to 5% is actually a pretty good amount. There's ones that are even less than 1%. So I'd say the second most common mutation other than EGFR is actually ALK.
We've talked about a couple biomarkers now. Why would it be important for a patient to know which biomarker their cancer has?
So like you said, there's a lot of different biomarkers, right? But some of them actually mean something. So what that means, they're called targetable mutations. And the reason they're called targetable mutations is because, all cancers are mutations, but not all of them are actually have a drug specifically for that mutation. And EGFR and specifically ALK is one of those kind of targetable mutations. So that's why it's very important that a patient understands their kind of mutational status specifically for those two mutations, because there is a drug specifically for that mutation. A second thing is that, a lot of patients hear about immunotherapy, and when you have those mutations, immunotherapy actually may not work as well. So it's not the right treatment algorithm for a patient. So that's why these things are important.
It sounds like knowing your biomarker can not only improve your outcomes, but prevent poorer outcomes from happening.
Absolutely, it can guide your treatment. When I'm a surgeon, so in surgically resectable disease, there's a lot of new trials, and these come out, every year. They're changing kind of standard of care, and understanding the targetable mutations and how we treat that. I think all targetable mutations now in surgery are within the surgical patient are being treated. So it used to be that targeted mutations may not have mattered before in the surgical patient, but the newer data, the newer clinical trials have now shown that they actually help.
It sounds like no matter what stage your lung cancer is, it's a good idea to know your biomarker.
That's absolutely true. I think, what we've seen is that every stage now is undergoing something we call multimodality treatment, meaning more than one treatment option. And, stage 1 disease all the way to stage 4 disease is now being treated with different either targeted agents or immune checkpoint blockade.
Oftentimes, when someone's told they have lung cancer, their first thought is, let's get it out. As an ALK patient, that was my first thought too. Can all ALK patients get surgery? Should they get surgery?
That's a great question. And, surgery, regardless of mutational status, is really determined by the patient's stage. So the first thing you got to determine is the patient's stage. So certain stage of disease is actually surgically resectable, while more advanced stages are usually not. So that's what determines really, which way you're going to go. Because now what we're seeing is that surgically resectable patients definitely have another trajectory, another different treatment algorithm than the ones that don't. So if you are not a surgically resectable patient, you can usually get chemotherapy, radiation, followed by a targeted therapy. But interestingly enough, in alectinib specifically, or the Villena trial for ALK, has actually now come into the surgical resectable disease. So this trial showed that if you operate on patients that have an ALK-positive mutation, and then you give them alectinib or the treatment for that, they actually do better than just the standard chemotherapy. So like most things, these targeted therapies usually start out in late stage or unresectable disease, and have now gone into earlier stage or resectable disease. So I think right now all stages are treated by alectinib.
As a surgeon, who else should be involved in patient care, whether or not they have resectable disease?
So I think that usually lung cancer is such a complicated disease. It requires more than just surgery for the majority of patients. And what that means is that we try to get everybody involved. So we have something called a multidisciplinary tumor board, or meaning bringing people in. And these people include oncologists, they include radiation oncologists, they include radiologists and pathologists. You know, what that really does is brings in a team of experts that all have an expertise in different parts to kind of come up with a consensus to treat that patient. Because like we said, there's, one lung cancer does not resemble another lung cancer. There's a lot of different types of lung cancer, including ALK-positive lung cancer, and that undergoes a certain treatment algorithm. So understanding the expertise from all these different doctors is really important to reach a consensus, because there is definitely more than one way of treating a patient, and it can go different routes, right? So we really have to come together in order to see what's the best one for that specific patient.
If you were a lung cancer patient and you were at one of your early appointments, what are 2 or 3 questions you as a patient would ask of your doctors?
So that's great. I think that you have to be well informed. So I think the most important things are really what's most important for the doctor, which is what is my stage, what is my mutational status, and then what are the next steps, basically. For me, it would be, if someone asked me, am I a surgical patient, then I would tell them yes or no and tell them why. So these things are really important for every patient to know. There's a lot of patients that don't want to hear about it, but I think it's a disservice to the patient, right? Especially, if you go see another doctor, if something else happens down the line, you should know what stage you were, what your treatment was. So these things are really important.
Thank you so much for joining us. This has been really helpful. I know I find a lot of helpful information on lcfamerica.org, information about ALK and the other biomarkers. Thanks for bringing some clarity to it all today.
Of course. Thank you for all the important questions. And I think that a well-informed patient is always gets treated better.
Agreed.